uh, the idea was that so many of you, particularly those of you who are from overseas, they are not very clear about how to tackle in your exam. And by the way, the same is true in your day-to-day radiology management, because you have to put in management in your short cases and long cases, and as well as in the viva. And many of you are not very clear about that. The way radiology is practiced in UK is slightly different than the way it is practiced in many other parts of the world. And here it is, this is why we call it clinical radiology. And radiologists are actually, we lead the way, and we actually tell the clinicians what to do next and things like that. So these types of things are critical for you to know, and that is how you can answer, manage your exam also much better. So Sakib is an absolute expert in this, lot of insight, one of his favorite topics. And he, being an IR radiologist, he has sort of designed today's session as a special session, vascular and thoracic cases. And Sakib will tell you, because with some of his colleagues, they will do more sessions on this theme, and maybe the others will do the same thing in their subspecialty. So don't miss these sessions; they are going to be absolute gold. So Sakib, without wasting more time, over to you. Any introductory comments you want to make before you? I can be with you till you start the formal session. Over to you, please.
Exactly. Thank you so much, Dr. Khan, and good evening, everyone, and good afternoon for those of us in a different time zone as well. So I'm just going to share my screen to start with.
So I will stop sharing. Yeah, over to you.
Okay, just want to double check if everyone can see my main screen now before I start.
Managing the management. Yes, we
That's it.
can see.
Perfect. Excellent. Perfect. Thanks so much. Right. So, as Dr. Khan mentioned, this format of my session will still be along the theme of 2B Viva. That will be the core. But I want to take a slight different spin on the way we talk about these cases. So, yes, we will go through lots of cases, but I will always be asking a question. All the cases I've selected, there's a specific point we can talk about afterwards. Either you've seen the case before and you're confident and you know what the management is, and I just want you to attempt to describe what that management should be in a very succinct way. Alternatively, you've never seen or you've seen it before, but you don't know what happens after you've reported it. So hopefully we'll be able to share some knowledge. Or finally, you've never seen it before, in which case, hopefully this will be educational for you as well. Exactly as Dr. Khan said, the core principle of radiology is that we are clinical radiologists. And I'm really trying to push forward for myself and my colleagues to really make an impact on the rest of the clinical teams, that our knowledge is beyond what we see on a screen. And to the point where the example I give new junior trainees is the bad radiologist is the one that says lesion, lump, lesion, over to you, it's your problem now. The good radiologist is the one who understands there's a pattern to disease, trying to figure out what that pattern is, piecing it together, and giving a very succinct plan. So your report is not just a diagnosis. You now direct that clinician where to go next, who to speak to next, exactly what needs to happen next from the imaging point of view or management point of view. And that's really what I want to share today. And hopefully we'll be able to go through some techniques which I've found helpful. Um, Before we go on to that, one of the key things I've noticed, especially when it comes to the 2B Viva, I used to have the same problem. And I will try to, at some point, just to give that example, stop the candidates from answering, just so we can focus on what they may have said or may not have said. Because what will happen is you'll describe the findings. You've been talking for 2 or 3 minutes. And then I will ask you, can you please tell me what you think? And what will happen is, in the process of telling me your conclusion, you find a new finding. And all of a sudden, you're going back to the description again. And you're trapped in this never-ending cycle. And unfortunately, that 2 minutes becomes 5 minutes, and then the examiner's going crazy in this time. So what I really, really want all the candidates to focus on today is I want a concluding statement, one line, that summarizes everything that you've seen or the main finding that you've seen. In the same sentence, I want just one or two differential diagnoses that you think of. And again, in the same breath, go straight to the management. So this is a patient with a lung lesion. I suspect this is a malignancy. I would contact the respiratory team. So I want everything to be succinct. The, again, I don't want you to fall into the trap of describing new findings in your conclusion. Now, when it comes to the management, every single person will give you some different recommendations. I'll give you a very, very quick insight before we go into some cases, how I like to structure it. And actually, the information I'm going to give you was actually inspired by a GP colleague of mine who, during his viva examination, mainly seeing patients, was given the same sort of structure. And he told me there were three categories that he was told to focus on. What do you do as the referring clinician? What do I do as the radiologist in this situation? And what does someone else need to do? Now, what do these titles mean? I'll go through some separate points. So when you're telling the clinician about urgent finding, you need to explain to them, is it life-threatening? Is it urgent? Do they need to act on this fast? Are there specific blood tests or are there certain types of additional tests that need to be done for this patient? And any immediate treatment. There is nothing wrong with you suggesting an immediate treatment plan for some of these patients if you see an urgent finding as well. When I say this title of what do I do as the radiologist, what that basically means is what kind of imaging investigations would this patient need at some point? Or what kind of interventional procedures would this patient need? Something a radiologist can help with. And what does someone else need to do? Is there a specialist that needs to be involved in this patient's care? If so, which team is the most appropriate team for this patient to be involved with? So hopefully what we'll try doing is going through some example cases. We're going to be if you can if the candidate is happy to give me his or her own management plan, perfect. If not, we can always populate these three categories and formulate a management plan. So we'll work together, hopefully. So without further ado, candidate one, are you ready?
Yes, sir. Yes. Good evening.
Excellent. So to start with, the first few cases I'm going to show you will be based on my PowerPoint slides. So I will scroll for you. If you would like me to go back a step, go forward a step, is fine. The image interpretation, I will probably try to focus on one or two spot images. It's mainly a quick finding or a key finding I want you to describe. But I really want you to focus on going straight to the management, the conclusion, the differential diagnosis, and the management. Is that clear?
Yes.
Perfect. Excellent. Right. So case one, I'll scroll through for you.
Okay, sir. Sir, I'm provided with the CT scan chest with contrast. These are the arterial phase images in which I can appreciate there's a dissecting flap identified seen involving the thoracic aorta. It is seen extending into the abdominal aorta. And yes, okay, sir. Sir, I can appreciate that the right renal artery is seen rising from the true lumen. However, the left, I want to check the left branch. Sir, some areas of focal few cystic areas in both kidneys. So right renal artery seen arising from the true lumen. I want to check further, sir. And yes, sir, there's a dissecting flap also extending into the SMA, superior mesenteric artery. Yes, sir. Here I can appreciate there is an extension of the dissecting flap into the, I think, as I want to check, is either SMA or celiac artery. I want to scroll more, but it's extending into the superior mesenteric artery. Yes, sir. And superiorly, yes, sir. Sir, I want to see the extension above. Yes. So, sir, this is the type 2, type B stand for the aortic dissection, in which it is extending or seen primarily involving the descending aorta with its extension into the main branches, like I think celiac artery or
stop for a second.
involved.
Stop there for a second. Yes. I hope the rest of the people on the call can now see what she's doing. And this is exactly what I meant. In your conclusion, you are now going back a step, and now you're telling me all the descriptions again. Do you see what I mean now?
Yes.
So where you said your first line, perfect. This is a Stanford type B dissection. That's all I wanted to know. That is your key finding. But now you're starting to tell me about it now goes here, it now goes here. Now we're trapped in a loop. So now do you see the problem you create? This is the key thing. And I'm going, remember, we're all learning from you now, but you will never appreciate it. The other people in the chat hopefully will have seen what's happening. But anyway, carry on. So let's just start again from your conclusion.
Yes. Okay, sir. So this is Stanford B type, this aortic dissection. So this patients mainly conservative management can be done, but I think this is a complicated one because it is seen extending into the branches as well. So I think intervention radiologist role can be there. There can be a branch stenting we can apply. So I will urgently convey my finding to the referring physician, and also the I will inform the intervention team. This patient needs to be discussed within the IR team because IR team can help into the branch stenting. So usually these are type B need medical management, but I want to discuss in the IR team and as well as the referring physician and
Okay. Just stop there. So
management
I'm going to
team.
ask you a question. You mentioned a complicated type B dissection. What do you mean by that?
Yes, sir. So it is seen extending within the branches, and further I want to check. There's no ischemic changes right now developed, but it's seen to be extending within the main branches. So in future, it may lead to ischemia of rest of the. Yes, sir.
But if there's no ischemia right now, does it still
Yes, sir. Right now.
classify as a complicated?
Yes. No, sir. Right now it's not complicated, but in future it may complicate into the ischemia
Okay.
of the
Perfect.
affected vessel.
Fine. Excellent. Right. So very nicely done. Actually, I think you did really well there with the descriptions. So the key thing is, especially when you see these dissections, the key points to remember in the context of these kind of urgent vascular cases, the arch vessel extension, the visceral artery extension, organ hypoperfusion and ischemia, as you mentioned. And the third thing is aneurysmal segments. So you did very well there. So let's try to go back a step and let's try to structure the management as we described the sort of the format I mentioned. So these are the categories that I've mentioned. I've given you a rough management plan over here. So the key thing you mentioned as well, urgent finding, excellent. Someone needs to know. The only thing I'd be slightly cautious about is that you mentioned the involvement of the intervention radiology team. Just be slightly careful. So if you know without a shadow of the doubt, this is the management plan, fine, be confident and you can say it. But saying things for the sake of saying it can cause you a lot of problems. So from an intervention point of view, we never stent into the visceral arteries in this specific scenario, ever. There is a treatment option we can offer for these patients, but it's never that. So just be slightly careful, because if you mention this as a management plan, you're certain about it and you're wrong, that can make it a bit of a difficult conversation. So the key thing, as you said, these can be managed conservatively. So when any of these cases, the common theme is these patients normally have a very severe high blood pressure. Aggressive blood pressure control is key. If you can manage the blood pressure well, you can completely cut the amount of force going into the pulse tract, and everything will occlude and remodel. And actually, these patients go pain-free and get discharged very quickly. From a radiologist point of view, what more do we need to do? Repeat imaging. We need to know, has this turned into a complex dissection? And I'm going to go through the criteria exactly what that means in a second. And usually that means a repeat imaging within the space of 48 hours. Now, let's just say that the IR team have nothing to do with this patient. Who needs to be involved? Vascular or cardiothoracics, in your opinion?
So vascular, in this type, vascular consultation would be more better. In this type B.
Why not cardiothoracic team?
So because it's not acute emergency, it's not Stanford aid. So I think the surgical opinion, yes, sir, we cannot apply in this case.
Good. So the right answer for this one is that it's actually the vascular surgical team. They need to coordinate the actual treatment for this patient. So it shouldn't be referred to the IR team directly. It goes to the vascular team. Then they will refer to the IR team. That's the official way things are done. Okay. So the key thing is this question of what is a complex dissection. So there are essentially three key features of a complex dissection. Either there is narrowing of the true lumen. So when you have a subsequent scan and you find that the lumen is further narrowed, that is considered a complex dissection. Second of all, persistent refractory pain. So despite adequate blood pressure treatment, the patient's severe chest pain is persisting. Number 3 is an aneurysmal segment. That's usually a chronic problem. It happens over time. Actually, there is a 4th one, organ hypoperfusion. Now, you mentioned that there was a dissection extending into the visceral arteries. Sure, it's a concern, but if there's no organ ischemia, you don't treat it. Essentially, if you meet any of those 4 criteria, the obligation is that this patient needs urgent treatment. So that's why it's important to put a phrasing. This is a complex dissection, urgent vascular treatment, because that word in itself is an alarm bell for the vascular surgeons. Okay, perfect. Right, let's move on. Case 2. Ready?
Yes.
Okay. So this patient presents with severe chest pain.
Okay, sir. Okay, so I'm provided with the CT chest. This is arterial face images, thoracic imaging, in which I can appreciate there is a longitudinal hypodense crescent density seen extending from the entire thoracic arch. It is yes, sir, it is circumferentially encircling the aorta, and it's extending. Yes, it's extending from the. It's primarily involving the descending aorta. I didn't find any dissecting flap in it, and I don't see any acute leakage or any pseudo aneurysm along this crescent hypodensity. Okay, sir. Yes, so there's
So just
no
focus on this image. Tell me about this image.
Yes, sir. So this is an intramural hematoma involving the descending aorta, and it is yes, sir. Some small outpouching and a small speck of calcification is noted. This might be a penetrating ulcer which lead to this hematoma formation. So I will check on other images as well. So this is basically intramural hematoma, and I am suspecting a small speck of calcification and irregularity along the lining of the posterior aspect. It might be to a penetrating ulcer as well.
Okay. Again, in the same breath, go straight into the management. You're doing really well. Now,
Yes, sir.
there's
So
awkward silence. Go straight into the management.
Okay. So management is also a Stanford B type of hematoma. This also need conservative management. This require pressure control, and we will also then again we have to repeat the CT and also manage it about the history of the patient. Also, we can follow the patient after 24 to 48 hours CT. We can see there's an expansion of this hematoma or any deterioration of the clinical findings. Then we have to other finding, but this seems to be a medical management because this Stanford type B type of hematoma. Yes, sir.
Okay. The surgeons are calling and they're asking, do we not need a non-contrast CT?
Yes, sir. We also, yes, I need to reconfirm through the non-contrast because high density crescent can be seen in this non-contrast imaging.
Okay, you've fallen from my trap. What more information are you going to gain out of a non-contrast CT?
The non-contrast CT will also check about the flap, about the calcification as well, if either is a true penetrating ulcer which is leading to the hematoma. And
My
also
question to you is there any doubt that this is an intramural hematoma?
no, sir, I don't think so. I'm pretty sure. I also want to check Hans unit of this hypodensity from this point of view. I also can see this in hemorrhagic thickening.
Yeah. So my point in this is so a non-contrast CT in retrospect is futile.
Yes, sir.
So if you are vetting this as a first time and a patient presents with you as a chest pain query dissection, that's when if the examiner asks you how would you vet this, then the answer would be a non-contrast scan and an arterial phase scan. But doing it in retrospect serves no purpose. The answer is clear. Okay?
Yes.
But
Yes,
fine.
sir.
So that's just a quick one. But anyway, you mentioned the management quite nicely there. Right. Let's move on to the next case. By the way, so just in case I do have any of the candidates that have worked with me before with these kind of cases, if anything is familiar or you've seen them before in previous sessions, there's a few ones I've used in the previous ones. Please tell me. I can always move on to another one. I've got lots of cases. Alternatively, don't tell me, and I'm hoping that you're going to nail the exam. Okay. Ready for the next one?
Yes.
Perfect. Right. Patient comes in worsening shortness of breath.
Okay, so this is the chest frontal projection of an adult patient in which I can appreciate this post interstitial marking. I also okay, so there is an homogeneous opacity noted along the right parahilar region. The hilum is okay, so the artery seen through it. This is in right. It shows a well-defined lateral margin, but the medial margin is not well appreciated. And also there is another density which is noted in the right upper zone peripheral base. So it shows somewhat some toning of the structure. I think this is in vascular structure in the right hilar region with the possibility of some infarct. So I'm suspecting this might be in pulmonary embolism because it's yes, sir. This is tubular density in the right hilar region with some patchy peripheral based area. So in this case, I'm suspecting any pulmonary embolism. I will compare. I will check the patient history regarding
Okay,
any
just
long
stop there
term.
for a second. Let's move on.
Yes, yes, sir.
This is the CT for that same patient. Just review these two spot images.
Okay, sir. Okay. Yes, sir. So this is okay. So I think so. This is lobulated homogeneous structure, which is seen invading, which is seen compressing the superior vena cava. Yes, sir. Sir, I want to see more images, but it seems to be in lobulated mass lesion, which is seen invading and obliterating the superior vena cava. The pulmonary trunk is seen to be spared. So this is in mediastinal structure, which is causing significant compression and luminal narrowing of the SVC.
Okay, go
I'm
straight to the
severe.
conclusion and management.
Okay, so sir, this is supposed to be an neoplastic lesion because it is causing significant compression over the SVC and adjacent structure. This require immediate urgent management because it is causing significant compression. So a vascular surgeon as well. I think cardiothoracic surgeon have a role in this case, and this need to be decompression because it's may lead to severe compression of the SVC.
Okay, so how would they
Yes.
decompress it?
So they can decompress by surgical intervention. So they can remove this lesion.
Have you ever heard of anyone having surgery for a mediastinal mass like this?
No, sir. They also have an intervention role. First, sir, need to be assess what the lesion is. It's
Okay, so let's go back a step. Let's try to the additional key thing, but let's try to populate this now. So,
yes, sir.
what do you need to tell the clinician first of all?
Sir, I need to know the extent and the involvement and also the right atrial, where this mass lesion is going. It's involving the right atrium. It's involving how much extent it's involving and
Okay.
what things is and collateral formation or
Sorry, just to
also
clarify. So we're on the management part now. Forget the findings now. You've got your finding. You've got your
Yes,
conclusion.
sir.
This is malignant SVC obstruction. That is your
Yes, sir.
conclusion. So now, what do you do? So what do you need to tell the clinician who's referred this to you?
Sir, this may lead to this need to be so surgically it should be relieved. We can I think a filter can
Sorry,
also
so
be helpful.
fine.
Yes,
So
sir.
let's just say this patient's come to the emergency department.
Yes, sir.
What do you need to tell the emergency physician now?
So this is causing significant compression of major vessels, and it may extend within the vessels, and it cause thrombosis of SVC, and it may progress into the rest of the uh, ischemia, and it can be cause complications. So it can extend and also causing significant compression over the major structure. This may cause pulmonary arterial hypertension, and this cause
So
strain on the heart.
what you're doing there is that you're telling me more
Yes.
about the findings of the scan. So just be slightly careful. So this is what I
Okay.
mean. So just knowing. So and for again, we're trapped in the same loop again. You're telling me more findings. You're telling. I'm asking you other questions. You're
Okay.
telling me more findings. So just once the
Okay.
findings are done and the conclusions done, no more findings. Finished. Okay. So what I mean, I'll give you an example. So first of all, someone needs to know. You sort of did mention this. Someone needs to be told urgently. The next thing is we're dealing with an SVC obstruction. All the medical textbooks have told us this is essentially a medical emergency, right? So we need
Yes, sir.
someone to go and find this patient, and he needs to give us an assessment. How severe are your symptoms of SVC obstruction? Because based on those symptoms, we'll make a decision of how we manage this patient. And we'll go through the exact who needs to be involved, who needs to do what in a second. But there is a grading system available, especially in the UK. So depending on the degree of symptoms they have, the ones we tend to be involved with are the ones who essentially fall into grade 3 or grade 4 category, where they have facial edema, laryngeal edema. The severe cases are those patients who have got such severe cerebral edema that we need to now do urgent stenting regardless of the underlying pathology. So a lot of the time, these patients, they can give them steroids. Have you ever come across this before?
No, sir, I didn't come
So
across.
again, there is nothing wrong with you as a radiologist. This is a very common emergency management of these patients. Give steroids. You can make that recommendation. It shows that you now have knowledge of the condition beyond the radiology. Okay.
Yes.
The problem in these situations is the pressure is on us. We now have to demonstrate we know more than what's in front of us on the screen. So this is your chance to sort of shine. Now, what do you as a radiologist need to do? Here's where it gets interesting. So staging CT, if it's not a known malignancy, biopsy, because a biopsy is paramount. So if this is the lymphoma, it gets treated very differently to a primary lung cancer or a metastatic cancer. Okay, lymphomas potentially, especially if it's a young patient, you start them on the right treatment, this lesion melts away within weeks. So they need a biopsy more than anything else, as long as they're clinically able. So if they're in that grade 1, grade 2 category and they can wait, the focus should be on the biopsying and the staging. This is really the management that I'm interested in, the SVC stenting. And I'll come across exactly how that works in a second. Now, what does someone else need to do? The two teams that do not have anything to do with this patient, unfortunately, are the vascular surgeons and the cardiothoracic surgeons. Yes, they do get involved in teratomas, anterior mediastinal masses. They do get involved in a resection. But in someone who has malignant SVC obstruction, you can argue who needs to be involved, whether it's a respiratory team or hematology team, or if it's a known malignancy oncology team. Because one of the treatment options is radiotherapy. If you can give radiotherapy, that in itself can reduce the symptoms as well. Does that make sense? So if these patients come back and they have this grade 3 or grade 4 category, that's when the interventionalist gets involved. And this is just a very, very quick example of what happens. This is an oblique projection, and you can see over here, we injected some contrast through a sheath downstream, and it's completely obstructed, a trickle of flow going down. Once we've placed the stent through, this is a guide wire going through and through. This is part of the right atrium, and this is a guide wire going to the IVC. This is a stent connecting the superior vena cava to the atrium. And this is a CT scan that shows it patent exactly what it does. So this is what the function of this is if the patient has severe enough symptoms. Once those symptoms are controlled, then they can work on diagnosis and further management. These are normally palliative procedures. So does that make sense to what I just talked about?
Yes.
Perfect.
So I want to ask, yes, sir. This I want to ask, it's an acute emergency, like we have to stent first and then we back to biopsy
Again,
and management.
go back a step.
Yes, sir.
Only if
Yes, sir.
they're grade 3 or grade 4. If their clinical symptoms are so severe that it requires these. Often I come across so many cases where the patients come into A&E, they're coming through ambulance, no one's mentioned, someone mentioned a cough, or no one's mentioned shortness of breath. Or they've mentioned shortness of breath, nothing else. They've gone through A&E and no one's mentioned anything. They've gone through the medical team, no one's mentioned anything. They have a CT chest done. Incidentally, there's an SVC obstruction, and all of a sudden now they can see distended veins. Now they think that this is an emergency, whereas all these patients actually have zero symptoms. So it depends on their symptomology, which dictates what we do next. Okay?
Yes, sir. Yes, thanks.
All right, let's move on. Just review the spot image, please. This patient is known to be on dialysis, but is having poor flows during dialysis sessions.
Okay, sir. Sir, I can appreciate there is an catheter draining tube is seen, and it's okay. Sir, I want to check its tip. I think its tip is into the I think it's little bit superior place is in the superior vena cava. It's not at its ideal position, which is at the level of the right atrium and superior vena cava junction. So I think it's a little bit superior displaced. And apart from this, lung fields are grossly clear, and there's no sign of pneumoperitoneum or a pleural effusion in this X-ray. And regarding the bones which are grossly
Bones over 5.
normal.
So if it's not in the
Yes,
SVC,
sir.
where is it?
Yes, sir. And SVC, sir. Okay, sir. Sir, the fold is a little bit on the left side, so there is a possibility of a left SVC, but its tip is not clear in this image. Where is exactly its tip? Yes, sir.
The tip is at this level here.
Okay, sir. So there's a small kink is noted, and it's within the area. So it's a yes, sir. So right-sided SVC is right-sided, but there's a small kink, and okay, sir. I think there is an lucency noted along the medial aspect. Might be something is pushing this stent medially.
It's all clear, nothing like that.
Yeah. Okay.
Okay, if I tell you there's an anatomical structure where it's located in,
Okay.
does that help you?
Structure. Sir, then we see the left-sided SVC are usually there, but their tip is toward the left side, which is
so remember in the exam, and actually during my examination for 2B as well, I was tested on, I was asked anatomy questions. So again, whenever you've seen a left side SVC, where does the left side SVC drain into?
Yes, sir. Sir, left-sided. So they usually on the left side and drain into the coronary veins, and then they
so
open into the
is that anywhere
yes,
near the coronary vein?
No, sir. Coronary vein side is not here.
So just be careful with it. This is the point I want to make. So just
yes.
be careful with the statements because you are meant to be the master of anatomy.
No.
So this is your time to demonstrate your anatomical knowledge as well.
Yes, sir.
So anatomically, what other structures are in that region of the SVC?
Sir, there is a azygous vein also.
Yes, perfect, exactly right. So that is in the azygous vein.
Yes.
Okay. So yeah, it's just this is just a refresher that you will be tested on anatomy knowledge as well, or functional knowledge, things like that. So just be mindful that the examiner can ask you these kind of questions as well. I was asked specifically about an endotracheal tube that was in the bronchus intermedius, and the examiner wanted me to describe the anatomical landmarks in that region. Okay, perfect, fine. Right, next case, spot image. Tell me what you see.
Okay, sir, I can appreciate, sir, these are the MRI weighted images post contrast in which I can appreciate there is an band or is an there's an narrowing noted at the isthmus part of the arch of the aorta, and suspecting is a coarctation, and it's involving just beyond the, I think, superior vena cava. This is in part of isthmus, and there is multiple collateral formation which is predominating along the back along the intercostal and back muscles. So it is a coarctation of aorta. Yes, sir. Sir, okay, sir. Yes, sir. There is also multiple collateral formation along the anterior chest wall.
Stop. You did so well. You did so well. And I thought you were going to nail this one.
Yes, sir.
You did perfect. You described everything I needed to hear. You told me this coarctation. I thought the next word was going to be the management. And then you started telling me about collaterals again. Be careful. You're doing so well there. So stop there. Conclusion is done. Coarctation. Excellent. Perfect. Let's move on.
Okay. So
because remember, as an examiner, you've hit the 6 marks. Are you worthy of a 7? Prove to me you're worthy of a 7 now.
Okay, so management depend on the patient status. If it's a patient developing some cardiac hypertension and some cardiac it's a hypertension and it's symptomatic and it's then we have a management of the surgical. Otherwise, we take it's a conservative surgical treatment. Usually needs end-to-end bypass and grafting. And we can also refer to this interventional radiology as well. They might place a stent in this place, but it's the management depend on the medical medical condition of the patient. If it's developing hypertension and it's heart straining is more, then we have to opt for surgical or IR intervention.
Okay. Fine. So just a slight correction. So just for you, And remember, this is where, when you go to MDTs, this is where you learn from the actual clinician you're speaking to. Because once you
Yes,
speak to
that's
them and
good.
you know what their limitations are, what they can and can't do, you can then
Yes.
appreciate what the surgical procedures are. They never touch this part of the aorta, ever.
No.
It's so hard to get to unless they take this entire patient's chest cavity out of the body. So remember, when they do bowel surgery, laparotomies, they can lift the bowel and move it out of the way, and they can get to the retroperitoneum. In the chest, they can't move the heart, they can't move the lungs, it's all there. So for them to
Yes.
get to this, to replace it, that surgery doesn't exist. Or if it does, I've never heard of it before. The management here is just the stent. They
Okay,
just put
sir.
a stent
Thank
across, that's all.
you. Okay, sir.
Okay? So just be
Yes, sir.
slightly careful about suggesting surgical techniques that don't really exist. Okay?
Okay. Okay, sir.
Fine. But yeah, exactly right. So the key thing is, remember, structure the whole management. So this needs to be, is this an urgent finding? Is this a life-threatening finding? Does someone need to know about this now?
Sir, it's depend on the condition of the patient. If the patient is hypertensive or is developing cardiac strain and pulmonary hypertension, then we proceed. But it's a long term. It's already
No. So the question I'm asking
established.
you, does someone need to know about this problem right now? Is this an emergency finding?
No, sir, it's not an acute
Fine. So
emergency.
this is what I mean. So
Yes.
we're just trying to populate. Remember that the whole mention I had before about trying to populate the management plan. What do you, the
Yes, sir.
referring clinician, what does the referring clinician need to do?
Yes, sir. Sir, I need to know these, like it's associated symptoms.
No.
It's either
Not what
it's
you
mild.
need to know. Not what you need to know. What does the referring clinician need to do? What advice do you want to give
Referring.
him? What do you need to do?
Sir, I will convey my finding to the vascular and
Okay,
cardiothoracic surgeon.
fine.
Yes,
Yep.
sir. And then
Perfect.
I will tell about the collateral formation, about the extent
He
of
doesn't care.
this.
It makes no difference to him.
Yes, sir. Sir, this patient needs sir, medical assessment of the symptoms,
Yes.
like it's
Yeah.
developing. Yes, sir. So we grade it about the according to its medical assessment. It's either it's acute synocope ischemia or then we have to go further.
Okay. The main issue is that it's the cardiothoracic team or the cardiologists that are involved in this patient's care. They're the ones that put the stent in. They're the ones that deal with these patients. They're the ones that manage the blood pressure issues as well. Because remember, a lot of these coarctation patients, they might have secondary syndromes, Marfan syndrome, tetralocephalic
Yes,
history. They may have a history of VSD or ASD. So there are some
yes,
other associated features that are commonly seen with coarctation. So they need to be screened for
yes,
these things. Okay. Again, you, by
yes,
saying this point, it just demonstrates you have the knowledge about these kind of conditions beyond what you're seeing on the screen. Does that make sense?
okay, sir.
Okay, I
Yes,
think we are slightly short of time, so we might have to move on to the next candidate. Very well done. I think the key feedback for you is, especially if you get around to doing this, try to adopt it in your day-to-day practice. So you're populating those titles yourself. And ideally, at some point, you need to try and make sure that when your conclusion is said, that's it. You do
yes,
not go back a step. Otherwise, you're trapped in that endless loop. Don't make that mistake. Very
yes.
well done, though.
Thank
Okay.
you. Thank you,
So
sir.
next candidate, candidate two.
Candidate 2, are you with us? Candidate 2?
Okay, we can move to candidate three if they're available, or should we wait?
I think candidate 2 is with us. Must be some. Let me check. Just hold on, please. So, candidate 2.
Yes, sir, I'm here. Can you hear me?
Yeah. So, okay. Over to you, Sakib, and candidate 2.
Hello, candidate two. Perfect. So, are you happy with the way we've been doing things? Are you happy to go around the same route of the management plan as we've been doing? Any questions
Yes,
before we start?
yes, sir. No, sir.
So you don't have to use those management titles I mentioned. That is just as a guide. Use it, ignore it. If you've got something better, tell me about it. It's entirely your choice. Okay, so we'll go through some similar cases. These can be some of the ones I'm going to show you might be slightly trickier, but the key thing is a quick description, and I want you to go straight to the management, and we'll talk about that in more detail. Ready?
Okay, sir.
So ignore this one for now. That's not the one. Let's do this one. So, ready? I'll scroll for you, and then if you want me to slow down or focus on a specific area, we can do so. But I will
Okay.
go through some key images. Over to you. Okay, what do you think?
Yes. There is aneurysmal dilatation of the abdominal aorta, and stenting has been done. There is active leak of contrast in the dilated aorta. I am suspecting endoleak. I would like to know the proximal and distal extent to delineate the site of the leak and its type.
Okay, what do you think of this image? Just review the spot image.
Yes, sir. Sir, I'm suspecting endoleak type 1.
Okay.
And I would refer this patient to the interventional radiologist for further management of leak.
Okay, so just to let you know, just because I'm an interventional radiologist doesn't mean everything has to come to me. So just because I'm hosting the session, so it's so me being as a host is a trick question because everyone thinks that the right answer is refer to the interventionalist. Yes, I might be involved in the care, but I'm not the one they send to. So try again. Who else? First of all, let's keep simple. So this is a endoleak, okay, with a rupture. So just keep so the conclusion needs to be very, very clear. This is this is a aortic rupture secondary to an endoleak. That's it. It was those few keywords. My management is. So first of all, does someone need to know about this?
Sir, referring clinician, I would inform the referring clinician as it is a emergency case.
Perfect. Beautiful. First point done. Excellent. Okay. Next point. Further imaging. Is there any further imaging that's necessary, or are you happy that you have all the imaging you need?
Sir, no further imaging is needed.
Perfect. So who's the right team that this person needs to be under? Which specialist does this patient need to see?
Sir, interventional radiologists for angiography and restenting or stunt replacement.
Okay, but remember, there has to be someone I'm working with. There has to be a team that looks after this patient, right? Whose domain is the aorta?
Sir, a vascular surgeon.
Yes, the vascular surgeon. Yes, remember, the interventional radiologist, generally speaking, in the future, I don't know, but at the moment, we're not an independent team. Majority and predominantly most of our work is based on referrals. So we work with other teams. It's very, very rare for interventional radiologists to work independently from the rest of the profession. So we are working with them. Okay, so just be slightly mindful of that. Okay, but yeah, so how many endoleaks do you know of?
Yes, sir. I could not hear you.
How many endoleaks do you know of?
Sir, there are five types of endoleaks.
Okay, so Have a look at where this contrast is coming from. Any idea what kind of endoleak this is?
Sir, can I see other
Nope,
coronal
just this
section?
one. This tells you everything you need to know. So I'll go through the so for me the disadvantage is I deal with this on a daily basis. Obviously not everyone deals, and especially where you might work, they might not be doing any EVAR, so you never see any EVAR stents. So this is actually an example of a type 3 endoleak. And the idea is that you have what we call, and actually I'll show you the next one. Each EVAR has 3 components, what we call a main body, and then we have limbs. And the idea is that these limbs go inside the main body. And then can you see there's a slight line there? That's what we call a seal zone. So what happens is that these limbs go inside the main body here, and they act like a continuous stent. But because the idea is that these are meant to overlap, they can become detached, especially if there's increase in size. There are all sorts of reasons why it's very, very rare, but these limbs can become detached. So knowing that it's a detached limb, that's where type 3. So I'll go through the endoleaks very briefly so far. So the type 1 and type B, these are typically, because remember, the idea is that you've now covered the aneurysm. So if you have a type 1A leak, you have lots of blood coming into the sac, or even from below, you have lots of blood coming into the sac at fast flow, but it has nowhere to go. So the risk of rupture is extremely high. Usually you find out about these straight away. They happen during the time of insertion. Rarely they can happen later on down the line. Type 2 is extremely common. We see these all the time. If you have a type 2 endoleak, but the sac size itself is the same and hasn't increased, you leave it alone. As long as the sac size hasn't changed, the type 2 endoleak does nothing at all. Because what will happen is the type 2 endoleak will come in, they'll find a small microchannel, and then it will somehow come out on an outflow. Okay, so it doesn't actually pressurize the sac. Type 3 is if there's a defect in the graft, or if where you have this overlap, you have loosening or it's slipped away, which is the case we have. So you have slipping away. Again, this is just as severe as type 1. You've got rapid filling of the sac, but nowhere for it to go. So it pressurizes and it ruptures quickly. Type 4 and type 5, I would ignore. They're that rare. This one is ideally, the idea is that it's the porosity of the actual graft, so you get a leak anyway. And type 5, so we've got endotension. I would ignore these 2. It's only really these 3 we're concerned about. Okay?
Okay.
Perfect. Let's move on. So, patient presents, young patient with severe hypertension. The renal physicians have asked for an MRI. Please review this image.
Yes, sir. These are MR angiographic images of abdominal aorta and renal arteries, in which I can appreciate multiple stenosis and dilatations in the mid segments of bilateral renal arteries, giving a beaded appearance. I am suspecting, as patient is young and the findings are involving the middle segment of the renal arteries. I'm suspecting fibromuscular dysplasia. So I would inform the referring physician of my findings and would recommend referral to the interventional radiologist for stenting. Yes, sir.
Again, don't fall into the trap of just because I'm an interventional radiologist saying all the answers of interventional radiology. So remember, there has to be some logic behind which patients I see. Very well done. Let's talk about the management further. Okay. So the key things are, so you said the buzzword, which is the most important thing from a description point of view. So let's try to populate the examiner. So what does the clinician need to do? You've told them that they need to assess, they need to be obviously informed of the finding. Any further imaging this patient needs?
Yes, sir. Fibromuscular dysplasia involves renal arteries and carotid and multiple
Yes,
other arteries that.
exactly
So I
right.
would recommend multi-system evaluation.
Perfect. Exactly right. So that is part of the management, right? So this is where I said that description of what can you as a radiologist do? Recommend further imaging. What kind of imaging? The carotids, exactly right. The next thing is we know that there's obviously an issue of stenosis and hypertension. So that is where the interventional radiologist, and it's not a stent, it's an angioplasty. So the idea is that we
Oh,
normally
yes,
put
sir.
a guide right through, we stretch it open the balloon, and they respond very,
Yes,
very
sir.
well. The problem with stents in a young person is that stents eventually block
Yes.
down or break down. And then once that breaks down, game over. There's no way of salvaging that stent usually. So we normally do an
Okay.
angioplasty if it's severe enough and they fail medical management. Okay?
Oh, yes,
So
sir.
that's the key thing. So carotid Doppler to assess carotid involvement, and if there's a hemodynamically significant renal artery stenosis. So here, there's lots of stenoses as FMD, but is there any severe critical stenosis here?
Um,
The answer is no,
uh,
because it would be
yes, sir.
very, very distinct and clear. Okay,
Yes, sir.
so this patient may not need any management. Medical management may be sufficient. So not everything requires intervention. Okay,
Okay, sir.
perfect. Right, let's move on. So I'm going to go to some spot images. This patient presents with worsening chest and abdominal pain. I'm just going to show you a few spot images and tell me what you think. Or just focus on this image alone. Okay. Remember, awkward silences are the wrong thing. So even if you don't know what's going on, no problem. Just start talking. And you can talk by saying CT thorax in the arterial phase, portal
Yes.
venous phase. So start the
Yes.
conversation going.
So I have been provided with CT axial section of chest in arterial phase, in which I appreciate as mild thickening of the descending aorta wall.
Okay. Differentials.
Sir, there is no calcification or
Stop.
plaque
Don't get caught in the
formation.
trap. Don't get caught in the trap. I asked for differentials, and you're now showing me more findings.
Yes, sir. Sir, it could be vasculitis.
Okay, keep the conversation going. This is your time now to completely nail the management. Have a think for a second. What can we do for the management for this patient?
Yes, sir. Can I see images from the
No more images.
abdomen?
Finished. No. Forget the images now. You just need to go straight to the management.
Okay, sir. I would inform referring physician of my findings
Perfect.
and
Good.
would recommend steroid
Straight
patient
away.
and for systemic evaluation regarding vasculitis.
Yeah. Good.
Yes, and recommend steroids and then a follow-up scan.
What kind of scan?
CT scan
Okay. There's a few more things with this
to
one.
see
Yeah,
the
keep going.
improvements.
Okay, fine. So trying to populate and using this template again. So what do you do as a vasculitic screen?
Yes, sir.
It's implied when you say vasculitis, the implication is they do a vasculitic screen. Absolutely right. Steroids should be considered. The problem is if you do steroids, you might limit the next investigation, which is absolutely game changing in the world of vasculitis. PET CT. So PET CT in large vessel vasculitis completely shows clearly pre-treatment exactly where the areas of concern are. If you give steroids, you can potentially dull that response. So ideally, you want to do PET CT first, but also you look for complications related to the vasculitis. And usually that means stenosis of the arch vessels or saccular aneurysm formation because of the inflammation. So these are the important negatives that you need to mention. Which
Okay,
team does
sir.
this patient need to be under?
Sir, vascular surgeon.
Why the vascular surgeon?
Sir, rheumatologist.
Yes,
As
rheumatologists.
yes.
So key thing is making sure, again, you're not the first person to say vascular, but the vascular surgeons have nothing to do with this condition at all, unless there's
Yes.
some kind of a complication like the sacral aneurysm, of course. But in a standard diagnosis, there's no role for the vascular surgeon. It's the rheumatologist that leads everything. And the PET CT, if you were to see
Yes,
it,
sir.
shows nice avid enhancement of the arterial wall. Perfect, good. Right, let's move on. Next patient has worsening swelling and pain in the leg. I'm going through some spot images for you.
Sir, I have been provided with MR axial images of left thigh and hip joint, in which I can appreciate extensive inflammatory changes around the left hip joint. Sir, can I see the images in which femoral vessels were visible? Yes, sir. There is lack of signal void in the femoral vein with surrounding enhancement. So I'm suspecting this is thrombosis, and some infective or inflammatory process is going on. So, sir, that can be thrombophlebitis.
Why do you think there's an inflammatory process?
So there is extensive hyperintense T2 signals in the surrounding muscles.
Why is that? So put two and two
Sir,
together.
yes, sir. This is venous thrombosis, femoral venous thrombosis. So I would inform the referring physician of my finding and recommend the urgent anticoagulation, start the anticoagulation, and rule out the cause and find the cause of the prothrombing state that has led to the thrombus formation.
Okay, good thinking, good thought process. So is there anything unusual about this specific one? Let's focus on this image here. Is this a standard DVT or is there something more concerning that you want to mention? Forget about
Yes, sir.
the high signal. Let's ignore the high signal for location. Tell me about the location of this thrombus.
Yes, sir. There is a collection with surrounding enhancement seen in the pelvic cavity.
So just be slightly careful. Again, one of the
That
key
is,
mistakes people
yes.
make is saying it's a contrast scan and a non-contrast scan.
Yes, sir. So that is abscess formation that needs to be.
Okay. So I think so. Remember, so you've already got you've established, and you did really well. You've established that this is now a filling defect or a filling defect equivalent. All of this is just extensive edema. So not everything that's bright means inflammation. Inflammation and edema,
Oh, yes,
they
sir.
can look the same in certain regards, right? So all of this is all
Yes,
just
sir.
extensive edema. And can you see the edema is specifically within the retroperitoneal space over here? And this is an iliofemoral DVT. That is a trigger word. As soon as you say the word iliofemoral DVT, this is now managed very specifically to the rest of the world's DVTs. Okay, this is not managed the same way as a small popliteal thrombus or a thrombus in the brachial vein, nothing like that. This is managed very differently. Why?
Sir, I'm not sure.
Exactly the reason you're seeing on the screen. Can you see the effects of what it's caused? So remember, all of those, the reason DVTs in the leg cause swelling and improves quickly is because you have lots of collateral pathways. Veins form so many collateral pathways, it can bypass the obstruction. But if the obstruction is so extensive and so proximal, even where the bypass channels come in, they've got nowhere to drain. So what happens? You get edema of the entire region, the muscular edema, retroperitoneal edema, because there are no draining veins anymore. So you just get a huge amount of swelling. But if this breaks off and this travels to the lungs, that's life-threatening. That's where the 50% mortality comes from in PEs. So this is a huge PE risk, okay? Especially if they were to start anticoagulation
Yes.
right now, the chance of all of this breaking off and traveling to the lungs is extremely high. That's why it's managed a very specific way. Have you ever heard of an IVC filter?
Yes, sir.
Exactly one of the indications for this. So for those who
Yes.
aren't aware, so we can insert these essentially umbrella-shaped hooks. We actually come in from the jugular vein. Under fluoroscopic guidance, we normally mark the infrarenal arteries and we park the actual filter. As long as the actual IVC is clear of thrombus, we park the filter there. The logic and the reason for this is if this patient was to have that big iliofemoral DVT break off, it will just get caught in these struts, or the big pieces will be caught in the struts. You give them the anticoagulation and it slowly dissolves over time. But because you've saved them from this life-threatening large thrombus, the patient lives. These small little hooks that are in place all keep it in place. And the idea is that these are all collapsible. So as soon as you put a tube over the end of these, everything collapses all the way down again. So these are quite nice products. They're retrievable and they've completely changed, revolutionized the way we treat DVTs. So that's one of the indications. Any other indications for IVC filter insertion that you can think of?
Yes, in patients in which anticoagulation is not possible or they
Excellent.
are getting a recurrent DVT.
Not necessarily, not for a current DVT. It's really those two. That's it. So a very large iliofemoral DVT, so
Okay.
above the guidal ligament into the iliac veins, or if the patient has a contraindication to anticoagulation and they need to be treated on some and they have things. So if this patient has, for example, an upper limb DVT, would you put an IVC filter in? And they can't have
Sir,
anticoagulation.
for upper limb DVT, IVC filter would not work.
Exactly right. It's just a quick point because some people say, remember, the idea of the IVC filter is meant to stop any blood clots from below going up.
Yes.
If the blood
Yes,
clots
sir.
don't exist below, then there's no need for this IVC filter.
Yes, sir.
Okay. But the key thing, this is where the manager is very specific, though. The clinician needs to be involved. No further imaging is necessary. We've already got everything we need. This is where we need to have a discussion with the hematology team. And this is a situation where interventional radiology for consideration of an IVC filter. And then the indication for it is large iliofemoral DVT, high risk of pulmonary embolism, IVC filter temporarily for helping. Or there's one more option. We can treat the DVT directly. We can do an have you ever heard of aspiration thrombectomy?
Okay, sir. Yes, sir.
Have you heard of it?
Yes, sir.
So the idea is we normally puncture the popliteal vein, or sometimes we come in from the top, and we essentially suck out the large pieces of thrombus. We suck out as much as possible. If there's a tiny residual in the popliteal, no one was ever going to die from that. It's those big iliofemoral ones that people are going to die from. So we can put a small tube inside and we can suck out as much as we can. And we can instantly relieve the symptoms. Perfect. Okay, let's move on. So just review this spot image for me.
Okay, so there is a large soft tissue mass in the retroperitoneum. It has central low attenuation and it is displacing the aorta towards left. So can I
This is
see
the only image you
the...
have. Let me just show you. Just focus on the IVC. This is the IVC here.
Yes, sir, I could not appreciate IVC. I'm suspecting that it is thrombosed. So I would like to see any arterial phase.
No further images, just these.
So it could, my differential includes cell, a large abscess, but there is no inflammatory finding surrounding inflammatory
Just to clarify, have you
evidence.
ever seen an
So
abscess look like this?
it looks like a mass
Yes.
So I'm suspecting it is a malignant mass because it is
Okay.
invading the IVC and occluding it. So I would like to see the whole of the series to see any metastasis, and would recommend and would inform the referring physician of my finding, and would recommend the biopsy and MBT discussion.
Excellent. So the hematology team have been involved in this patient's care, and they've said, can we please get an IVC filter for this? What do you think?
So it is too extensive. I guess IVC filter would not be beneficial.
Why not?
I'm but said that needs to be discussed in MDT.
You're in the MDT. You're discussing it right now.
Yes, sir. So there are options of IVC stenting, because it would not be possible to remove a large segment of the IVC or do grafting.
No.
If it
So
is
you're going
possible,
a
I'm
few
not
steps.
showing.
You're going a few steps beyond what I'm saying. So what they've said to me. So let me go back a step. Let me put some context. So typically, I told you the position of the IVC filter is below the renal arteries. You've just seen over here that the entire IVC is obstructed up to the point of the renal arteries here. These are renal arteries. That's the renal artery. This is right up to that junction. So they've
Yes,
asked
sir.
me to put a IVC filter in the suprarenal segment, which is up here, which is possible. It's not a problem. We do it in pregnant women all the time because of the way the fetus compresses. Should I
Okay,
do it
sir.
or should I not do it?
Sir, I'm not sure.
So I can put a filter in. Should I do it or should I not put one in? Is a question I'm asking.
Sir, I'm not sure.
No problem. So the key thing is that, yes, it's a huge abdominal mass. It's obliterated the IVC, but this image actually shows that it's invading into the IVC. It's not just compressing. Can you see over here? It's perfectly contoured to the region of the IVC, right? So it's gone into the IVC. It's invaded into the IVC itself. This is now, the key word is tumor thrombus. Tumor thrombus is fixed to the actual lesion itself. It's not separate. So what can happen is at the caps, can you see there's some low attenuation here, some low attenuation here, low attenuation over here? What can happen in these cases is that because of the stasis of flow, you can get what we call bland thrombus, normal thrombus, forming at the edges. But the volume is so small that an IVC filter won't do anything. The majority of the problem is the actual mass itself in the vena cava. Yeah, that will never break off. It's not mobile. So if I was to put an IVC filter up here, that will never actually migrate up. The treatment for this is you treat the underlying lesion. Does that make sense?
Yes, sir.
So the key word is tumor thrombus. We do not put an IVC filter in for tumor thrombus.
Okay, sir.
Okay?
Yes, sir.
Perfect. Fine. This actually turned out to be a germ cell tumor in a very young patient. But yeah, that's and then all we need to do for this actual bland thrombus, just to prevent it from getting worse, because remember, once thrombus forms, it can keep propagating. So he does need
Yes.
anticoagulation just to dissolve all these elements up, but it will do nothing to the main tumor. Last case
Okay.
before we go for a quick break. So I'm just going to ask you to review this one image in a second and just tell me what you think. Go
Sir,
over to
there
you.
is a large heterogeneous. I have been provided with MR sagittal images. Uh,
Go straight
T2
to the
sequence.
diagnosis. Straight to the diagnosis.
There is renal cell carcinoma with renal vein thrombosis.
Anything more?
The renal vein thrombosis is extending to the IVC.
Okay. Do you know anything about renal cell carcinoma staging?
Yes, sir.
What stage is this for bonus points? Remember,
If
this is your point. If you know the case and you're confident about the case and you know this information, don't wait for me to ask you.
Yes, sir.
Show the examiner you know everything. If you've done a succinct description, you've done a good succinct management plan to start with, show him that you know more than rather than me prompting. So this is, as you said, mass, blah, blah, blah. This would be in keeping with the stage XXX.
Yes,
Yeah?
sir.
So what
Yes,
stage
sir.
is this?
Yes, sir. As it is involving renal vein and the IVC below the liver, then it is T3A or T3B. I'm
Perfect.
not sure.
That's fine. T3A/B, that's perfectly fine. That's why I've done the MRI. Next question they've asked me, can we please put an IVC filter in? What is your answer?
Uh, yes, sir. I guess there is a possibility because it is not completely occluding the IVC.
Or why do I need to do it?
It is
Remember,
narrowing.
tumor thrombus.
Oh, yes, there's too much thrombus.
Yes, so tumor thrombus. So remember, if you ever see, and remember, YouTube has so many videos. You do not need to be a renal surgeon to look at renal surgical videos. It's for me to know, I also do a lot of urology. For me to sit in the MDT and appreciate the recommendations I'm making to them, I have to know a bit about their job. When they do their robotic surgery, when they do their open surgery, when they do these nephrectomies, partial or complex, I need to have an appreciation of how they do it, why they do it, when they don't do it. Just look at these surgeries. It's good bedtime watching before you go to sleep. And what happens is when they remove this, actually, because this thrombus isn't invading the walls, what happens is it simply peels away. So when they remove it, it's actually very satisfying to watch. They pull back and the entire thrombus comes out in one continuous piece all the way out of the IVC. And then they just patch up the hole. Okay, so it doesn't invade. If it does invade the actual wall, and that's the reason MRI was done, that is now T4 because
Okay.
now that's a much more complicated system. The purpose of the MRI is to check, is it just inside the vein or is it invading the vein, the walls of the vein? Perfect.
Okay.
Excellent. Very nice job. I hope that makes it. Any questions for me?
No, sir, not from my side.
Excellent. Perfect. Very nicely done. Dr. Khan, I think we're ready for a quick break.
Okay, just yeah, take a break. It will be a 5-minute break, but I'll make an announcement. You can switch off your video, Sakib, if you want.
Reading some of the comments. Sorry, there's so many comments that I can't really respond to all of them. Unfortunately, I won't really get too much of a chance either. At the end of the session, I will leave my email address, and if someone wants to email me direct, I can. I'll look at a quick couple of questions that people have asked. One of the questions is how a tumor thrombus can go into the lumen without invading the wall. Very common in RCC. And again, watch one of those videos of IVC tumor thrombectomy, and you'll know exactly what I mean. It almost peels back, and you can see the whole thing all in one block. And if it's true invasion, like the previous case I showed, you'll see that the actual entire tumor is completely inseparable from the wall itself. You cannot identify the IVC wall. And it just kind of molds directly into the lumen itself at that point. So that's really, and at the MRI, you normally will see the actual signal of the luminal wall as well. If you have obliteration of that wall, that's what gives you an idea that there's wall invasion. And that's why an MRI is typically done. But whenever you see any RCC patient who has suspected IVC thrombus or renal-based thrombosis going close to the IVC, an MRI is the gold standard for that exact reason. They are waiting for confirmation, is the IVC wall involved, or surgically when I go in, when I peel back this tumor, will everything come out in one piece? That's what they're looking for. Because a patch on the IVC is a much more difficult operation that requires a few more specialists like vascular surgeon specialists. I'll do one last question. Oh, so what's the management of the case with IVC extensive tumor thrombosis? Hope for the best that treatment works. The truth is diagnosis is the most important thing. So germ cell tumors typically can be quite responsive to chemotherapy treatments. So treat the underlying cause, treat the underlying tumor, radiotherapy, chemotherapy, whatever the tumor is sensitive to. The only thing you can really do is remember I showed you that there's caps of bland thrombus. When we have bland thrombus, is normal thrombus. Because remember, there's something called Virchow's triad that tells you when a thrombus forms. And one of the key factors is stasis. Wherever you get an occlusion, you essentially have turbulent blood flow, slow blood flow. And if that stays in prolonged and a hypercoagulable state, thrombus will form. So just to prevent that thrombus from getting worse, you can start anticoagulation. But the key point here is tumor thrombus versus bland thrombus. The distinction needs to be made whenever you see these kind of cases. Same thing in the SVC. We see a combination of two. Even if you have a malignant obstruction and malignant SVC, you can also see bland thrombus above and below. Right. So I think we will continue with the next candidate. So, if we have, apologies, I've just noticed a thing, because I'm using a laptop screen, I'm projecting onto a second screen. My cursor I've been using on my laptop screen, that's why you wouldn't show, but I will use it on the main screen next. So, candidate 3, are you ready?
Assalamualaikum, sir.
Sorry, I can barely hear you. Say that once more.
Assalamualaikum.
Walaikum salam. Excellent, perfect. Your voice is still slightly low. Either you're not speaking loud enough or your volume's very low.
Yes. Sir, it's
Or you
okay
need
now?
to scream. Slightly better. Scream this time.
Sir, now it's better?
Excellent, perfect. Now I can hear you loud and clear. So, can you see my screen?
Yes, sir.
Excellent, fine. Right, candidate 3. So we're just going to go through some cases. Remember, my focus with you will be the management. Yes, we'll talk about findings, but I'm more worried about the rest of the conversation. What do we do next? So over to you. This patient presents following a fall.
These are frontal and lateral radiographs of abdomen and lumbar spine images, in which I can appreciate that there is there is complete collapse of D12 vertebral body with preserved intervertebral disc space, and also there are marked spondylodegenerative changes noted. Few phleboliths are noted in the pelvis, along with
Perfect. That's fine. Let's move on. So this is the same patient, presents with worsening shortness of breath 10 days later.
In this, this is the post dorsal lumbar spine internal fixation image with chest radiograph. In chest radiograph, I can appreciate there is slight distension of right descending pulmonary artery noted. I could not appreciate any focal lung parenchymal abnormality, no discrete mass seen, and I can not see any other finding. So if there is any history of recent operation, then the patient might present with deep pulmonary embolism. So I would consider CT chest pulmonary angiogram for further evaluation.
Just before that, what kind of surgery has this patient had?
Sorry?
What kind of surgery has this patient had?
This is cementing with internal fixation.
Okay,
Kyphoplasty.
perfect. So what do you think of the actual lung vasculature peripherally?
There is a paucity of vascular marking seen.
Paucity.
With yes, central prominence and mild increased vasculature in the lower zones also noted with atelectatic changes and slight
What do you think of
internal.
this? What do you think
Yes,
of these
these are
branches here?
yes,
These.
these are slight internal hyperdensities are noted. These can represent cement embolism.
Perfect. Carry on.
So I will advise CT pulmonary angiogram for further evaluation of this case, and I will inform the referring physician and urgently involve the respiratory team as well as the cardiothoracic team for management of this case.
Okay, let's take a step. So the CT radiographer has called you and has asked you, oh, we just need to do this CT chest that you've asked for. How should I protocol it?
For CT pulmonary angiogram?
Do you want a CT pulmonary angiogram or anything else?
I think CT pulmonary angiogram.
So what will the CT pulmonary angiogram show you?
Pulmonary embolism.
But are you worried about pulmonary embolism or are you worried about cement embolism?
Cement embolism.
So what will the CTPA show you?
I will advise HRCT.
So just take a step back. So HRCT, remember, the purpose of HRCT, the specific recons they do, are looking for interstitial lung disease. Keep life very simple. A non-contrast CT chest is sufficient. So
Okay.
if your suspicion is that this patient has cement embolism, or if you're also trying to look for another differential diagnosis or an alternative cause, a CTPA could be reasonable. You can also have, remember, you've now got a obstructed flow now. So you can actually have a pulmonary embolism on top, but you need to do it as a non-contrast, as your negative to confirm the hyperdensities, and then you need to do whatever other phase you want. Make sense?
Okay.
But remember, don't get people involved who don't need to be involved. What do you
Yes,
think a
yes.
cardiothoracic surgeon will do in this patient?
No. These will resolve spontaneously.
But you're the one who said we should get cardiothoracic involved.
Yes, that
So
was,
just
I
be
think, for
slightly careful. Yeah,
pulmonary
so just be
embolism.
slightly careful. Try to. It's good to suggest the recommend. Respiratory team is sufficient, perfectly fine. They're the right people to be involved in this kind of patient's care. But the key thing is to make sure that you're not involving people who have no business being involved in such a case. Okay,
Okay.
great. Right, let's move on. So I'm going to scroll through the images for you. Go to the main images and just tell me what you see. Oh,
These are axial sections from HRCT, mediastinal window, in which
actually,
two
hold that thought. I'm going to give you a
mediastinal
different case. Sorry, hold that thought. I'm going to give you a different case. I'm going to give you this one instead. Sorry, I'll scroll to the images again.
and these are axial sections from contrast enhanced CT, thorax, pulmonary vessels are unremarkable. There is soft tissue noted. There is soft tissue noted along the left ventricular outflow tract. So it can be any mediastinal mass. There is also mediastinal infiltration noted around the pulmonary vessels, as well as
Just talk to me about this. What does this look like here?
This is circumferential involvement of vessels noted. It can represent mediastinitis or any infiltrating mediastinal mass.
Okay, what's this in the middle?
It's some vessel. It can be some pseudoaneurysm formation.
Okay, so let's go back a step now. So let's remember, this is one of those what we call story cases. Look beyond this. So let's look at some additional findings around the screen to see what else we can do to put the story together. Any other significant? Let's just go to this image, for example.
Can be some thrombosis. I will also check the coronal and sagittal images.
These are the only ones. So I'll go through this one again. What do you think this looks like? What is this?
And this is along pulmonary vessels, aortopulmonary window.
Just here in the middle, where my cursor is. What is this? I'll trace it for you again.
Some contrast examination.
Okay, so this patient had a stenotomy. What do you think about the LAD?
These are the calcified vessels or a graft surgery.
So what would this be then? So now let's piece together the puzzle. What does this look like now? Considering that he's had stenotomy and look how heavily diseased his LAD is, what do you think this is?
Pulmonary bypass surgery.
Exactly right. So this is a patient. So now, what do you think this is?
This is a pseudoaneurysm formation post-operative pseudoaneurysm.
It'd be very unusual to get it there. Normally, the pseudoaneurysms would form at the actual anastomosis if it was to happen. So around about this level over here, or this level at the sinus. So this is essentially aneurysmal formation or the actual bypass graft or the bypass opening. So they sometimes when they use the left anterior memory artery, that can actually still become aneurysmal, depending on the flow dynamics. So management, please.
So I will refer the patient to cardiothoracic team for echocardiography and further management of this case.
So this patient
Thrombosis
was
can
an
be done.
outpatient, and this scan was done for shortness of breath.
So thrombolysis, anticoagulation.
Oh, thrombolysis will make this guy bleed. He will die with thrombolysis. So
So
remember, the key
anticoagulation
thing
treatment should be
is
done.
so this is an aneurysm of the bypass graft. So the key message here is someone needs to know about this soon. In the same way that if you've ever reported an aneurysm in the abdominal aorta and you say impending aneurysm rupture, this needs to be treated because this patient will die imminently if this was to rupture, right? So as soon as you've seen such a big aneurysm, this vessel, if you think about it, should only be 2 or 3 millimeters in size. This aneurysm is huge. It's about 2 or 3 centimeters, more than 10 to 20 times its size. So you need to be slightly mindful of management. So this is urgent management, urgent referral, and emergency referral to the cardiothoracic team. And they need to essentially open this patient up, resect everything again, and start all over. Okay? But if this the reason for this one is just the key message of this is a surgical emergency. This should be treated as an urgent surgical case. Okay?
Okay.
Right, let's move on. So let's review this X-ray.
This is the frontal radiograph of chest of an adult female patient, in which I can appreciate there are extensive widespread areas of consolidation noted in bilateral lower zones and right upper zone. I will take the history of the patient, check the clinical record of the patient, and check the presentation. Whether is there any history of trauma, because I cannot appreciate some posterior. I appreciate some fractures in the posterior ribs. Cardiac size is also enlarged. There is, I think, aorta. Aorta is preserved, however, there is unfolding of aorta seen. Right-sided pleural fluid
Let's
is
move
also
on. So
noted.
this patient then had a subsequent X-ray. What do you think of this now?
In this X-ray, central venous line is noted as well as NG tube in the ICU setting. So there is marked interval progression of the disease process with complete whiteout of both lungs seen. So this can be acute respiratory distress syndrome secondary to major injury to the patient. So can I know the history?
So the patient, this is the same patient from before, so worsening shortness of breath, unresponsive, respiratory failure.
So it can be secondary to acute respiratory distress syndrome or cardiogenic syndrome. I will immediately arrange the CT scan for further evaluation.
So let's go through the tube. So you mentioned the IJV line, the NG tube, the ET tube.
Yes,
What are
ETT tube is
these?
ETT tube is located in right bronchus.
Okay.
So I will immediately call the referring physician to pull up back this tube because it is causing the collapse of bilateral lungs.
Is that why it's collapsed? Because,
Uh,
so if your concern is that this is causing collapse of this lung, then why is this lung collapsed?
Central venous
So
line
let's go back
is
to the main question I asked. What are these?
upper is central venous line.
That's the central venous line.
Yes.
Have you ever
And
seen these before?
so central venous line I have seen,
That's
but
okay. So you may not have seen this because it's quite specialized care. Have you ever heard of ECMO?
ECMO. Yes, sir.
This is an ECMO catheter. So my
Okay.
next question to you is, what kind of ECMO catheters are they? What orientation are they? Do you know what kinds they are?
Sir, kinds of ECMO.
Yeah.
Sir,
So
sir,
try to go back anatomically. Where does this look like it will be anatomically?
sir, inferior vena cava.
Okay. And the other one?
Sir, superior vena cava.
Perfect. So what kind of ECMO? So when they talk about type of ECMO, they'll either say venous or venous arterial.
Okay,
So
okay.
this patient, let's go back a very quick step. As you mentioned, very nicely done. Extensive consolidation. I can't see the rib fractures. I think that's unfortunately what happens is when you're in the hot seat, every line starts looking abnormal. Just be slightly careful again. Don't say something that isn't there. But nonetheless, if I'm sure the examiners have some leeway. But the problem you'll have is as soon as you said trauma, everything is now trauma. That might look a bit dislocated. That might look a bit lower. That might look a bit widened. So just be slightly careful. You lead yourself into the wrong path. Okay. Keep life simple. Here is extensive actual consolidation worse in this lung, right? So the subsequent X-ray, essentially this patient, the reason everything looks so consolidated, this extensive consolidation, the purpose of the venous ECMO is in patients who have respiratory failure. Venous arterial ECMO is in patients with cardiorespiratory failure. So essentially, this has completely given the lungs rest. For all intents and purposes, this patient is no longer breathing anymore. These tubes are doing the oxygenation entirely for this patient. Whereas the venous arterial catheters, they're typically used in situations where these catheters are doing the pumping of the blood around the body as well now. Okay, so just have a quick read through these ECMO catheters. Unless you've seen them before, you'll never know what they are. And they can ask you these lines. They come under the category of lines and tubes. Make sense?
Sorry, sir.
Did that make sense?
Yes, yes.
Yeah, perfect. Right, let's move on. So I'm going to just scroll through the images. And the pressure's on you now because you've seen the previous candidates, the slideshow I gave them. So I want you to nail the management.
These are axial sections from CT thorax, in which I can appreciate there is a long segment. Intimal flap is noted involving the arch of aorta as well as the descending thoracic aorta, extending into the I want to see its proximal extent, but I think it's proximal to origin of subclavian artery, so it is type 1 aortic dissection. I will check its whole extent and also look the involved branches and the organ perfusion. It is emergency, and I will immediately inform the referring physician and involve the cardiothoracic and vascular surgeon for surgical management of this case.
Excellent. Perfect. So that's it. The key thing is type A dissections, only surgical option, or this patient dies. That's it. There is no second to it. So if this patient's frail, unable to have surgery, unfortunately, that means palliative care is his only option. This patient will not survive with a type A dissection. This needs an aortic arch replacement. Perfect. Nicely done. So let's move on. I'm going to challenge you a bit now. You may have seen something like this before, or you may not have, but let's give it a go. This patient has a history of swelling in the left leg.
And these are axial sections from MR T2 weighted images.
So make life easy for you. I want you to try and figure out what's not there.
Yeah.
So if I was to take, for example, this image here,
Femoral vein. One.
or this image here,
IVC and bilateral common iliac arteries are visible.
is that the IVC?
Sir, double IVC?
Where's the second IVC?
Sir, can you please scroll up again? Sir, IVC is visible, aorta is visible, and it is extending into the bilateral common iliac arteries. Common iliac arteries. Bifurcation of IVC.
So let's track. So where is the left common iliac vein and common iliac external iliac vein?
I think left femoral vein is not there.
Left femoral vein is here. But what do you think of it? Normal or abnormal?
This is normal.
We'll also compare. We have the symmetry, right? So
Yes,
does
yes.
that look like that?
Yes.
Okay. So what
Yes.
happens to it? So let me tell you about this one. So the idea is that over here we can see. Have you ever heard? So when you look into the context of chronic pulmonary embolism, what are you looking for in the pulmonary arteries to make
Pulmonary
a diagnosis? To make a diagnosis of chronic pulmonary embolism, what kind of features are you looking for inside the pulmonary arteries?
Sir, there is, sir, in chronic pulmonary thrombus, there is, sir, obtuse angle is noted, as well as there is, sir, some obstruction or remodeling seen.
Okay, one more thing, key thing, the main thing that they look for. Webs.
So
This is an webs, intravascular webs. This is an intravascular web, and it's a cardinal sign of chronic venous thromboembolism. So over here, as we trace up, the vein is obliterated. You can see how atrophic that is, and non-visible. It's absent almost. So you have the right, and the secondary sign is, look at this huge collateral that's draining. These are cross-pelvic collaterals, so it's diverting all the flow from below the inguinal ligament all the way to the other side. There's loads of these collaterals. And there is completely obstructed flow, chronic obstructed flow. Now, to make up for it, why is there chronic obstruction? We'll review this image here. This is the vertebral body. These are the two arteries. This is the actual common iliac vein on the contralateral side. What's this underlying patient's diagnosis?
So there is compression, sir, May-Thurner syndrome, in which there is
yes, exactly right. Yes, this is May-Thurner's compression, and that's what's caused acute DVTs. And acute DVT left untreated for a long time, because even though the DVT was probably there, because the vein was compressed at that point, the thrombus has nowhere to go. So over time, that vein just completely atrophies, it scars, and it's gone. And unfortunately, these patients have long-term leg swelling. What can we do to treat this patient now?
Sir, I will inform the referring physician and also involve the interventional radiologist. Angioplasty or stenting can be done after anticoagulation treatment.
Mm-hmm. So, what if she's asymptomatic?
Sir, if asymptomatic, then relieve symptoms, improve blood flow or compression stockings.
Perfect. Yeah, these are all things that are valid points. So yeah, the key thing is assess the symptoms. If there's significant symptoms, patient can be considered for intervention by getting through the vascular surgical team, and they involve us, okay, as the intervention radiologist. All right?
Yes, sir.
Perfect. So this is a May-Thurner's compression, and the idea is for anyone who's not sure what that is, that as the actual next CT scans you see of the pelvis, you'll see that it's very common to have slight impingement, but in May-Thurner's you have complete obliteration. If you can see like a sliver of vessel, that's not really May-Thurner's. Everyone always has that to an extent, especially slim people. But these patients typically have virtually no space between the artery and the vertebral body, and that complete compression leads to chronic thrombosis. And these patients can be treated with stenting. So you basically put a stent to reinforce that that channel, and it improves the blood flow and the direct supply. Perfect. So time-wise, we're okay. I will give you one more case, and then we'll move on to the next candidate.
Yes.
Right, so I'll go through this images. Patient presents with severe abdominal pain.
These are axial sections from non-contrast contrast enhanced CT abdomen, in which I can appreciate there is soft tissue swelling seen in retroperitoneum, peripancreatic region, para-aortic region. A marked soft tissue swelling is noted. I will check the superior mesenteric vein again. I feel that there is thrombus seen in superior mesenteric vein, resulting in its dilatation and peripheral fat standings.
I just review this last
Sir, I
image
will
here.
check
This
again.
one. So your diagnosis.
Sir, I will check the portal veins as well, because there is a distension and tumor thrombus, distension and filling defect noted in portal vein as well.
So your
So it is a
diagnosis.
long segment thrombus involving the portal vein and superior mesenteric vein. So I will immediately inform the referring physician and refer the patient to interventional radiology for further
Don't
management of
keep falling into the same trap. Every single one of the candidates there falling into that. Just because I'm an interventional radiologist doesn't necessarily mean everything. The trick part of this, there is a role for the interventional radiologist, but just be careful. The interventional radiologist does not primarily manage the patient. He needs to be referred to the team. Which is the right team that he needs to be under? Who needs to take charge of this patient?
Sir,
who should be the main consultant looking after this patient?
Sir, vascular or gastroenterology team?
What role will the vascular surgeons play?
Vascular MDT? Sir, vascular MDT or?
But again, why will the vascular surgeons be involved?
So
this is where you have
gastroenterology.
to there has to be some logic in your answers. So have you ever heard of a vascular surgeon going anywhere near the portal vein?
No, sir. Sir, it should be
That's it.
referred to
Yeah.
gastroenterology.
Yes, or HPB is another option as well. Upper GI, HPB, all of these are valid answers. But those are the kind of people that need to be involved in this patient's care. So someone needs to know urgently. The HPB team are involved. Anything else?
Sorry, sir.
Anything else?
Sir, in this case?
Yeah. Not images wise. The findings you said are perfect. Management wise.
Sir, anticoagulation should be given to the patient.
Perfect.
Or
Excellent. Yes. Anything else?
Or thrombolytic therapy.
Okay. How would I give thrombolytic therapy?
Sir, catheter directed.
How?
Sir, it is, I think, we used to we dissolve the clot.
I know, but how? You're saying catheter directed. How do I get my catheter into the portal vein?
Sir, tips.
Excellent. Yeah, that's exactly right. So that's sort of like the last step of the management, but that's essentially where we're getting to. So nicely done. So well described. The key things in this case are, yes, portal vein thrombosis. You want to be talking about the extent. If it involves a splenic vein, SMV. The key negative here is any evidence of, although it's vein that it can cause venous ischemia. So remember, you get venous congestion of the actual bowel wall, you get edema of the bowel wall, and if you get extensive edema of the bowel wall, that also leads to arterial insufficiency, and eventually it can progress to an arterial type ischemia. So you can get bowel ischemia from a venous obstruction. That's the context of what I'm trying to get to. So the key thing you're looking for is, if you're not seeing it here, you need to watch out for signs and symptoms of bowel ischemia. Okay? But yes, you're exactly right. So the idea is, for anyone who doesn't know, a TIPS basically stands for transjugular portal systemic shunting. And the idea is we come from the jugular vein, we go into one of the hepatic veins, we insert a needle and direct it in the region of where we expect the portal vein to be. In this case, it's posterior. So we normally come in from the right portal vein, we aim a needle into this vessel over here, and then we can send a tube. Very tricky in the case of this one, but actually what can happen is that you can actually pass a tube through and through into the portal vein, park it in the SMV, and you can give thrombolytic therapy. Over time, that dissolves. Because the only hole that you've made is actually through the liver, it's actually a very low risk of bleeding. There are other alternatives. You can actually puncture the liver directly, go straight into the portal vein. The problem is you've now made a hole in the liver. So giving thrombolytic therapy over a long period of course will cause a horrific liver bleed. So the safest option is you put a stent through and through, similar concept to when they do it for chronic liver disease, and then that sort of gives you access into the portal vein circulation. Okay, perfect. Any questions about that?
No, sir.
Excellent. Very nicely done. So I think we're ready for the next candidate.
Hello.
Hello, candidate 4. How are you?
Hi. I'm fine.
Ready?
Yeah.
Perfect. So are you happy with the way we're doing things? So the main focus is management. We're going to have a discussion about management. I will show you some findings, describe as best as you can. What I want to hear from you is a really nice conclusion, one line. And in the same breath, you need to say, blah, 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 my management is, and go straight to the management. I want you to tell me, who do you need to tell? What do you need to do as a radiologist? Who else needs to be involved in this patient's care? At least three key pieces of information. Is that okay?
Yeah, sure.
Excellent. Right, ready when you are. So, first case. Patient presents with worsening chest pain and shortness of breath.
Okay, this is the frontal chest radiograph. I can see that there is a right-sided pneumothorax. There is no significant shift of the mediastinum to the left side. There's slight depression of the right hemidiaphragm. And there is also left upper zone mass, a cavitating mass with hyperdense lesion within. So I'm suspecting that, and there is no other lesions within the lungs. So in summary, this is right-sided pneumothorax with no definite tension, and left-sided upper zone cavitary lung mass. So my management is to request an urgent to call the referring physician and suggest needle insertion followed by chest drain if the symptoms is severe. However, as I cannot see significant shift of the midline, so I will discuss this with emergency physician for the need of conservative and follow-up. Then I will suggest also CT chest with contrast for further assessment of the lung mass and discussion in lung MDT and
just before you do that, so I'll show you the CT in just a moment. Just before you do that, so what would be an indication if this patient is asymptomatic or mildly symptomatic? What would be an indication for needle inspiration?
If mildly symptomatic or asymptomatic, I think most probably they will treat it conservative. It will be absorbed.
Does every single pneumothorax who's asymptomatic or minimally symptomatic get treated like that?
No, I think if there's tension there's signs of tension, pneumothorax, they
There's a
will.
step before that. So the key thing I'm trying to get at is, have you ever heard of the 2 centimeter rule?
Yeah, if it's but here I cannot see that the pleural line is separated from the wall, or the parietal pleura is not. There is no pleural line. I mean,
where do
at
we
the level
measure the
of carina.
Yeah. Where do we
Sorry?
measure the 2 centimeters from?
At the level of carina.
Excellent,
From
perfect.
the
So it's
lateral
essentially the
chest
lateral
wall.
chest wall. The mistake
Yeah.
people make is that I mean, it's right when you're reporting these things to measure the apex. You can always state that there's a 3 centimeter apical pneumothorax or 2 centimeter basal pneumothorax. The number they're looking for is the one at the level of possibly the carina, but essentially mid lateral chest wall. 2 centimeters is your cutoff. Once you reach that 2 centimeters-ish, that's when they start worrying about, because that's when it's safe. If they were to do a chest chain right now, they're going to go straight into lung. They can't get to the apex, they can't get to the base. But this is their area of safety and insertion. Can you see this is their, I'm not sure if you heard of the triangle of safety. This is where their triangle of safety is, in this region over here. So if there's an air pocket enough for them to put a needle in, they'll do it. If there's no space there, they won't do it. So that's where the 2 centimeter rule comes from. Make sense? So just going to show you a spot image, and I want you to tell me, what do you think is happening? What's your diagnosis for this patient now?
Okay,
Focus
so
on
this is okay. So this is axial images of the CT. Just like there is a cavitating lung mass in the left
Let's go straight to
upper
your diagnosis. What do you think is happening?
loop. Okay, it's I would first my differential diagnosis is aspergilloma on top of cavitating lung mass, as it's most probably dependent. Sorry, as it's showing dependent orientation of the intracavitary lesion. But I would like to check it after contrast to rule out any aneurysm.
This is contrast, so just be careful.
So I just, I mean, with the mediastinal window, I mean, to just rule out that it's vascular.
So just be slightly careful. Have you ever seen in your experience as a radiologist, have you ever seen a malignant lesion have that appearance? Normally, the cavitating lung masses is very, very
usually it will be thick walled. Yeah, shaggy. Yeah,
exactly right. You were right the first time. Stick with your diagnosis. Stick with your gut feeling. The problem is, the more you say, the more options you give, the more you defer your mind into things that don't exist. Because then aneurysm comes into the picture. Nowhere in the history of aneurysm has an aneurysm ever looked like this. So you were right the first time. Stick with your gut feeling in these cases.
Okay.
Perfect.
Okay,
Right.
so it's just can we have just a question? If it's a Rasmussen aneurysm, it can complicate a cavitating infection, not on malignancy. So I just I know it will not be that big, but can we put it in differential or just aspergilloma and it's
okay. Have you ever seen an aneurysm like that looks like this in the chest?
So it was small, I think.
There we are.
That's small.
That's your answer.
Yeah.
Okay. Fine. Right. So I'm going to try to drive down for you. So this patient presents with chronic cough and shortness of breath. I'm going to ask you to focus and just describe what you think at this level here.
Okay, these are CT chest axial images of the patient with shortness of breath. There is fibrotic changes within both lung loops, the basal segments. There is no bronchiectasis, no honeycombing. There is mild architectural distortion. So it's most probably an interstitial lung disease. There is the pleural sparing.
Great, perfect.
And
Conclusion.
peripheral include, yeah.
Let's go straight to your conclusion now. You said the buzzword, go straight to the conclusion.
So my first, my principal diagnosis is an interstitial lung disease.
What type?
My first possibility is it could be drug induced.
No. What type of interstitial lung disease? You said the buzzword for it, so you know
Yeah.
it.
Okay.
You said the word subpleural sparing.
Yeah,
What does that mean?
non-specific.
Yes,
It
exactly
can
right.
happen with
You know
non-specific
this.
interstitial pulmonary fibrosis.
Excellent. Management, please.
So I would refer this patient to respiratory team and suggest discussion in interstitial lung disease MDT.
Perfect. Good.
Yeah, and I would compare this with the previous images in
That's
CT.
that's fine. But fine. Anything else? Just as bonus points, any other management decisions or any recommendations you can make? Remember, the more information you give me now, the better you look.
Yeah, so it could be so we can suggest if it's a first time diagnosis, I can suggest investigation or interrogation for the cause. The patient might have collagen vascular disease or any drug, any medications.
Keep life simple. Just say respiratory team to investigate a possible underlying cause.
For the cause, yeah.
Yeah, I mean, small things that you'd like respiratory function tests. And if you know how to interpret respiratory function tests, this is your time to show off that knowledge. The respiratory, I would expect to see a restrictive pattern of restrictive spirometry. I would expect to see reduced coefficient. There's all sorts of things you can say if you know it. If you don't know that information, so be it. Keep life simple and just say lung function tests. It's a valid answer. But if you know the answer, show off your knowledge. You were doing really well there. Actually, you did very well. You said the buzzword. So once you said the buzzword, go straight to your conclusion. Excellent.
Okay.
Right, let's move on. So let me just adjust the window. So patient presents with cough.
Okay, this frontal radiograph of patient presented with cough. I can appreciate there's right paraspinal shadow in the lower mediastinum. The rest of the lungs appears unremarkable.
So
There's
let me
all
move
the
on.
fractures.
So
Yeah. So
nicely
I
done.
request a
So
CT.
what do you think?
Okay, so there is posterior. There is a well-defined mass lesion within the posterior lobe or posterior segment of the right upper lobe. It's subpleural in location. There is no internal calcifications or fat density. There is no cavitations. And the surrounding lung appear unremarkable. There is no communication with the hilar vessels. So this could be of pleural origin. There is no comatal sign to suggest that it's around pneumonia. I would
You're doing really well, and I don't know, you stopped all of a sudden.
I just want to
Go straight to your conclusion.
reach
Keep
to
life
the
simple.
diagnosis. Okay, so my principal diagnosis is to be a pleural pathology, pleural nodule. So this is not of fat density, so it could be
Again, I don't
pleural
want a
fibroma.
description. I don't want a description. I just want the
Okay.
conclusion.
Okay. So my first
So my
possibility
only
is to
counter
be
argument is look at the orientation of this. Why would you say this is a pleural origin? Can you
it's
see the acute angles that are forming? So where does that tell you? What is the epicenter of this mass?
widely based to the pleura.
Can you see that acute angle
But
that
it's
is
an
made with the
acute
pleural?
angle, yeah. But it's an
Exactly
acute
right. So
angle,
what does that tell you?
that it's pulmonary.
Exactly right. Subpleural.
Yeah,
Right.
subpleural pulmonary. Yeah.
Do you know anything about lung cancer staging?
I just
That's okay.
no.
So this is the kind of stuff. So again, even as a trainee or consultant, no, attendance to these MDTs is so vital because once you've heard 10 cases of lung cancer staging, by the 11th and 12th cases, you will know the staging so clearly and off by heart. So I would strongly recommend, especially trainees, if there are any trainees in this session, I would recommend lung MDT discussion attendance for that exact reason. You will only pick up and become so complacent with and understand the staging once you're regularly part of those kind of MDTs. So this one abuts the parietal, abuts the chest wall. So what stage does that make it immediately? But this is a T3 tumor. Okay, as soon as it touches the chest wall, it's a T3 tumor. It doesn't look like it's invading beyond the chest wall. It just looks like it's abutting the chest wall. So management wise, so remember when we went back, so who needs to know? Let's just refer to the respiratory team. Any further investigations? Staging CT, CT cap has been done. Anything else?
The biopsy. I will bring
Biopsy needs to be done.
interventional. Yeah.
Perfect.
Yeah. It's a
Anything
pleural.
else?
Yeah. Anything else?
Any further imaging
Maybe
that needs to be done?
PET CT.
Why a PET CT?
For staging.
But you've done a CT cap.
Already, if we
So do you
can
need a
go.
PET CT if you've done a CT cap?
No.
Absolutely, you do. So the guidelines have changed. So when you have a lung tumor and you're planning on treating it with a curative intent, you need to be doubly sure that there are no metastatic lesions elsewhere. So if you provisionally stage this as T3, N0, M0 on the CT cap, you then do a PET CT scan, whether you upstage or downstage. Or sometimes someone may mention in the radiology report, indeterminate, small, right hilar node. That can be N1 or potentially N2. And then the PET CT downstages it. One more imaging modality we need to do then for this patient. Considering this might be a curative patient, they can do a lung resection. One more imaging investigation do all of these patients get now? Brain. So we need brain imaging too.
Yeah.
Again, PET CT will not tell you if there's a brain lesion. The best people who who can repeat PET CT, I'm sure they can show you something. But generally speaking, these patients require brain imaging, either an MRI or a CT, although MRI is preferred. So for any curative or early stage lung cancer, T1, T2, or T3 tumors with no nodal or metastatic lesions, PET CT, MRI. If the CT captures metastatic disease or irresectable disease, there's not really any point of doing any further imaging unless there's actual neurological symptoms. Okay, so just so you're aware of the management, again, you can, if you were to say all of this in your answer, you could have given the most basic report of this finding. But the fact that you demonstrated a knowledge that's shown that examiner that you only know the information you do because you read it, you spent time in the MDTs, and you're confident, that is the time to shine. That will bring your mark from a 6 to a 7, a 7 to an 8, wherever it becomes. This is the time to show off your knowledge if you have it. Okay, perfect, excellent. So next we're going to do is right. So I'm going to scroll through these images. This patient has swelling and pain in her right arm.
Okay, these are MRI angiography.
Just review this image here. What do you think?
Mhm. The right subclavian artery is right. Can you? I cannot see the right subclavian artery or vein, so if you can scroll to
No.
see. Yeah, so our right subclavian artery is there, but the right subclavian vein is occluded. So this is a case of right subclavian vein occlusion. The axillary vein shows is patent, appears patent. So I would my next step to check for any previous imaging. If there's any ultrasound, a Doppler for the upper arm. If there's no, I would request a Doppler for the right arm to further evaluate the extent of the thrombus. I would refer the patient to vascular team to start anticoagulant. I would
let's just move forward. So they've, for whatever reason, the person who reported this MRI said the images are non-diagnostic, and they have now asked you, can we repeat the imaging? What would you recommend? How would you protocol it? So let's just say Doppler is an option, but Doppler is inconclusive. What else can we do?
I think this is the MRI without contrast. It's tough images, so we can proceed with a CT or MR angiography with contrast to confirm.
Okay, so how would you protocol the CT?
Um, 75 minutes after injection of contrast.
Okay. Rather than times of the contrast, what I'm looking for is any particular position the patient needs to be in.
No, the arm shouldn't be elevated. It should be breast down.
Okay. So the key diagnosis here is thoracic inlet obstruction.
Thoracic inlet, okay.
So the idea is we need to confirm, because when you're in a neutral position with your arms down, you might be able to see that the vein is patent and is present. But when you have the arms up or flexed, that's when you get obliteration and narrowing of that space. So it's arms down and arms up position, either in an MRI or a CT or an ultrasound, which is dynamic. Any one of those three can answer the question. MRI just has slightly better quality information, but you have a lot of artifact, a lot of movement, a lot of time. But either way, thoracic inlet obstruction, the key imaging you want to do is arms down, arm up. And what you're looking for is essentially this one, where you get the vein, which is now chronically occluded or compressed because of the patient in the arm up position. Make sense?
Okay. So why it's chronic?
That's just how it is. It's just chronic. There's no acute thrombus there. If it was an acute thrombus, you would see some kind of a filling defect. You can see over here, you've got like this pin. You can just about, it's a MIP image, it's not really great, but it's almost obliterated vein. It's very compressed as opposed to it being distended. Remember that DVT case I showed last time with an acute thrombus?
Yeah.
That was an acute thrombus. And this is a contrast scan. So you would see a filling defect if it was an acute thrombus. This is actually a chronic occlusion, but related to or actually, it's not really a chronic occlusion. It's just compression with the arms up position, but thoracic inlet basically. Right. So we're going to do one last case. Yeah. Sorry.
Sorry. So do we request an MRI for or any particular sequences for the thoracic inlet syndrome, like check
Key thing
any
is, so yeah,
brachial
so
plexus or something like this at the management?
absolutely right. So brachial plexus, the key thing is they're going to do a trick sequence or something that has multi-phases for arterial venous phases there, and they normally do a volume reconstruction. The main thing is the distinction for the veins and arteries, arms up and arms down, but they
Okay.
also do sagittal sequences T1 and T2 because they can physically see the actual pinch point and what's causing it. If it's a scalenus medius entrapment, if there's a mass lesion, if there's a cervical rib, so you'll have the anatomical consideration of what's caused it in the first place. Whereas this just confirms the diagnosis for you. Okay? Right, final case, and then I think we are done. So I'm going to show you this one. Sorry, give me a second. Right, I'm going to scroll through the images for you. This patient presents with worsening abdominal pain, fever, and sepsis.
So these are CT abdomen, pelvis, axial cuts with contrast. Okay, so I can see there's a large abdominal aortic aneurysm with a large hypodensity in the periphery and a patent central lumen. So the there are some gas foci within this the hypodensity, which suggests to be thrombus. There is leak or focal interruption of the calcification and the wall anteriorly with the gas focus tracking through, and a large adjacent collection. So in summary, this is rupture infected aortic aneurysm, likely mycotic aneurysm. So this is a surgical emergency. I would immediately call the referring physician and suggest urgent vascular team review. I would notify also the interventional radiologist for any possible. I think this is it will be a surgical emergency. They will operate.
Fine. So I
yeah.
think the next time I do any DKT sessions, I'm not going to write on there that I'm a consultant interventional radiologist, because otherwise you'll keep saying send it to the interventional
Sorry.
radiologist. It's okay. So I'll talk you through this case. This is a very tricky one, actually. So you're right. So a very large sac, lots of gas locules inside, and you can see extensive collection. And it's really good you picked up the defect. So ruptured aneurysm is basically the underlying diagnosis. Now, does that look like any other aneurysm you've ever seen before? Look how perfectly cylindrical this is. What do you think this is? Why does it look like that? Also look for secondary signs around as well. What's happened here?
Mhm.
Surgical scar, right? Why?
Yeah, was there any operation before, or
He did have an operation before. What kind of operation did he have before?
like EVAR, and is it removed or something like
So
that?
remember, EVAR means endovascular stent. We don't make a hole in someone other than the arteries.
Oh, okay. Okay.
So what has he had? And you can see over here, perfect, 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 perfect. All of a sudden, horribly scarred and atherosclerotic. What does that mean? And look at all the atherosclerosis on the side as well.
Mm.
So again, just appreciating some slight, I'm not asking you to obviously learn the textbook on every surgical technique. There will be an endless field to discover, but the idea is that when they do open AAA repairs, what they do is that, have you ever heard of something called, they call it a straight tube or a bifurcated graft? What that means is if there's a healthy vessel at the top, healthy vessel before the bifurcation, they cut out, they make a big incision in the middle, they scoop out all the thrombus, they replace or they reline the inside with a graft and they stitch it in place. And the final thing they do is the actual aneurysm sac itself, they wrap it in a jacket. The purpose of that is that that jacket that they wrapped it in is now protecting the graft. So this is an aortoenteric fistula. Here is actually the duodenum. And that defect with the duodenum has eroded into that sac, that jacket that they left behind, that's covering the actual native's tube graft. So all of that gastric contents has leaked into the aneurysm sac and expanded. But none of it, but remember, there's still a barrier. Remember, I told you this is a synthetic graft they put inside surgically. That's why it's perfectly intact. But nonetheless, this is a horrible, horrible condition, and patients rarely survive, but they need immediate surgical management. They need everything evacuated, lots of antibiotics. It doesn't work out too well for the patient. And you can even see over here, he's actually even getting erosion of the bone at the back end as well.
Yeah.
So it's been going on for a while, but it's probably got worse with the size of the defect there. Okay, does that make sense?
Yeah.
Any questions for me from any of the cases we've done?
No, thank you.
Excellent. Very nicely done, candidate 4. Thank you for your time. Right, everyone, thank you so much for tuning into this. I think that wraps up our session. I'm sorry, I won't be able to answer every single question. I haven't had a chance to even see the questions, so I'm not sure what they're like. If you give me a second, let me just stop sharing my screen for a second. Sorry, I'm so sorry. I've just noticed I made the same mistake. My mouse wasn't visible. It's because I'm putting my mouse on my laptop and it doesn't show on here. I'm so sorry. But let me just see. I will have to just, sorry, Dr. Khan, I'll just pick one or two questions that I've seen. Can we differentiate between aortic ulcer, penetrating aortic ulcer, and aortic hematoma? So I'll answer this a very quick question over here, first of all. So the idea is that one causes the other, as opposed to them being two independent entities. So in the same presentation I showed you before, it's usually aortic ulcer that causes the aortic hematoma. So what they're looking for, when you see an intramural hematoma, that is what they're looking for. They're looking for a small defect or tear in the intima that's led to that intramural hematoma. Think of an intramural hematoma as a precursor to a type B dissection. If you leave it alone and do nothing for this patient, eventually he'll have a full-blown dissection. All that needs to happen is a tiny bit more space needs to occur, and all of a sudden, all that blush will rush into that intimal plane. And it will separate the linings and it will cause a complete disaster. So that intramural hematoma, if you can deal with that problem early on with aggressive blood pressure control, you'll reverse the symptoms entirely. Very rarely, if the pain's very severe, they can put a small stent across it, but it's much easier to deal with than a chronic type B dissection. Because once a type B dissection happens, it can extend into the visceral arteries. And this is why, remember, when you protocol these scans, they do a full aorta. The reason for that is because the dissection can go from anywhere from the top all the way to the groin arteries. And when I mentioned that complex type B dissection, ischemia also includes the lower limbs. If you have a complete occlusion of the common femoral artery because the dissection extends all the way to the iliacs, all the way to the common femoral, you can actually present the type B dissection with an acute ischemic limb for that exact reason, because the actual false lumen has completely compressed and pushed it to the side. So that's one of the reasons we've scanned from top right to the bottom as well. I think we're done, Dr. Khan.
Sorry, finished?
Finished.
Okay. So thank you very much. Brilliant session as usual. So I'm sure everybody gained a lot from this. Let me project the feedback slide in tandem. So I think, Sakib, you were telling me that your team or
Yes.
your group is planning some other more sessions.
Absolutely
Can you tell
right.
the audience
So
about it?
yes, perfect. Sorry, I forgot to mention this. So absolutely right, as Dr. Khan mentioned. So I've got a group of colleagues who are working with me, and as I've sort of given you some details and management options and strategies for tackling vascular and thoracic cases, You'll hopefully very soon have the same options for head and neck, breast, GI, and GI and GU and MSK as well. So watch this space. Hopefully in the very near future, we'll be able to deliver these kind of sessions for you. And again, the theme will be focusing on talking through the management, or if there's any unique management steps, which is helpful to know about either for the purpose of the viva or even general knowledge, as long as it builds your knowledge overall.
Excellent. And hopefully this will be delivered within the next 3 months or so.
Absolutely. Yes.
Yeah. That will be great. That will be great. So thank you very much once again, Saket.